Thank you very much, Mohamed. Thank you. Thank you for the invitation, and a very big welcome to everybody that stayed so late at night to come and listen to talk about what we are all feel very passionate about, I'm sure, which is about trying to get the best outcomes for the stroke survivors that we work with. So I will share my screen and bring up my lecture. Okay, so as Mohamed said, the lecture that I'm presenting is about the...
It's so fine.
Sorry, Mohamed?
It's so fine. It's free.
Thank you very much. The lecture that I'm presenting is about what does the evidence tell us for training of lower limb skills after stroke. But as well as talking about the evidence, I will talk about practical ways of putting that evidence into practice and share videos and photos of the kinds of evidence-based interventions we can be using with the stroke survivors that we work with. We will have some pauses in the lecture at times to answer questions, and it's going to help with the sort of facilitation of doing the question and answer.
I was ready for you.
So this is the outline of the lecture, and I will bring up this slide through the lecture to bring us back to what section we're onto. And so I'm going to start talking about impairments after stroke. And the reason for this is because obviously when we look at people moving after stroke, we're always analysing what their movement problems are to see what their interventions need to be. And so we go through a process of identifying what we call their kinematic deviations. I hope that makes sense to you, so that we're identifying how their movement differs from normal. But then we're always thinking about what are the causes? What are the causes for the movement problems that we see? And that is really, obviously, the impairments that come after stroke. And so I think we really need to discuss what does the evidence tell us about the contribution of impairments to people's movement problems after stroke. And I think it's particularly important because historically there has been a lot of misunderstanding about what are the most important impairments contributing to people's problems after stroke. So to really analyse people's movement effectively, we need knowledge of normal biomechanics, and we need to be very aware of what's the contribution of the impairments after stroke to the activity limitations that we see after stroke. So this is what I'm covering really. What impairments are most associated with disability or activity limitations? What are the characteristics and prevalence of those impairments? And I'll talk briefly about the evidence for intervention. So historically, people always thought it was the positive impairments, particularly spasticity, that were the main contributor to people's activity limitations. So people would assume that if somebody could not dorsiflex in swing phase, they would assume that it was because of spasticity in the plantar flexors. And really, I think understanding of this has changed very much now, so that now we would assume that if people can't dorsiflex in swing phase, the most likely cause is purely just weakness of their dorsiflexors. But if you think that the treatment is spasticity, then that's where you would concentrate if you think that is the problem, that's where you would concentrate your treatment. So it really is very important that we understand what impairments are really contributing to disability after stroke. The research that started to challenge this belief around spasticity was in 3 areas. So first of all, people started to look at the agonist muscle, and so they started to measure. In that example, they started to measure things like the dorsiflexors and realised that lack of dorsiflexion in swing was because of weakness, not because of plantar flexor activity. The second big area, and I think we need to be quite clear on this, I don't know what it's like in Egypt, but in Australia, there is a lot of pressure to use Botox for everything. And I think we need to be very clear and say that there is no evidence that Botox improves people's function. It does have some good uses, but there's no clear evidence. And in fact, in the upper limb, there is clear evidence that Botox does not improve people's function. It's not quite so clear in the lower limb, but there's certainly no evidence to say that it does improve function. I can be quite clear about that. And then there's a very large body of research that looks at the associations between the impairments people have and their performance at the level of activity. And what you find there is that there's not particularly correlations between spasticity and people's performance at the level of activity. So this is some examples from that research. So you can see this table is a summary of reported correlations between impairments here and some measurement of activity across the top. And so correlations, where 0 would be no correlation and 1 would be a perfect correlation, and we're seeing something in between. If you have a look at the correlations between strength and balance, strength and walking, strength and arm function, you can see that there are some very high correlations there. Measurements of coordination, we also get high correlations between coordination and activity. Sensation is surprising, because you would think that you would get more clear correlations between sensation and activity, but it's very inconsistent. And tone or spasticity, also very inconsistent, but mostly relatively low, just occasionally some high ones. So the clear message here is that it's these two. It's strength and coordination is really what's associated with people's movement problems after stroke.
We can talk about its concerns about negative impairment, not positive impairment.
Yes, exactly.
That's right.
Worry about the negative impairments. That is the very clear message here. That it's the things that we lose. We lose strength. We lose coordination. Those are the really big things. We do often lose sensation, but that is not so clearly linked with people's function. So loss of strength is the one that really has the largest and most consistent associations with activity limitations. And there are really over 100 studies that show this. Talk briefly about the characteristics and the prevalence of the various impairments now. So I think we all know what spasticity is. It does appear to be adaptive, so while it can be present very early after stroke, it can become much worse in people that have not had as much rehabilitation. So it does appear to be an adaptive or a maladaptive, a bad adaptation as well after stroke. I think part of the reason why people have often thought that spasticity is such a big problem is because of the way it's defined and measured. So people often, and does this happen in Egypt, Mohamed, that people use the word tone and they might be talking about spasticity, but they might be talking about something else.
As the same impact, but it is really different. Tone, it is not as spasticity as the tone can contain mechanical problem, neurological problem, but spasticity is a neurological problem at first.
Yeah. Yes, and that's exactly the problem, is that tone really just means resistance to passive movement. And resistance to passive movement can be caused by contracture, it can be caused by pain, it can be caused simply because people can't relax their muscles. And so tone is a much bigger thing. It can be caused by spasticity, but there's a long list of things that can cause increased tone. And the measurement tool that is most commonly used around the world is the Ashworth scale. And the Ashworth scale measures tone. It doesn't measure spasticity. So tone can be many things. And so I think what we suggest in our teaching is that we do not use the word tone. We talk about, does this person have contracture? Do they have some excessive muscle activity? Do they have spasticity? But we try and define what the problem is so that in our communication, we'd know what the actual problem is. This is the prevalence of, this publication is reporting the prevalence of spasticity, but in most of these studies, the measurement is of tone. So it's actually really tone is that just the Ashworth scale that's being used. So you can see here that this is kind of the many studies reporting the prevalence of spasticity. It does, or tone really, as what they're measuring. and the overall prevalence is about 40%. And that's really overestimating. So because if you use the Ashworth, you overestimate spasticity by about 1/3. So this means that probably the true prevalence of spasticity is somewhere around 25 to 30%. And that 40% is people with increased tone. So you can see it is a big problem when we don't talk clearly about what the word is that we're using, and when we don't measure clearly.
If we can discuss with the audience about the main difference, what is the main difference?
Between tone and spasticity?
Main difference in systematic reviews, statistics. What is the main? Yeah.
Okay, so
What is main difference means in the systematic reviews?
About the way they've measured it, Mohamed, do you mean?
Yes.
Yeah, so in pretty much all of these, so here we have this systematic review, and each of these is a study that's reported the prevalence of spasticity. This line down the middle is sort of 40% here. Oh, sorry, where's my... And each of these studies has, or just about all of these studies have used the Ashworth. So you can see if this is the line of 40%, they're all reporting somewhere a bit below or above 40%. If you pull all those results together, the overall prevalence of what they have said is spasticity is 40%. The 95% confidence interval goes from 35 to 44, so it's quite a small, because you have so many studies pulled together, you have quite a small, so that means that the lowest likely and the highest likely effect is prevalence is between 35 and 44. But again, what we have to remember is that they've measured tone. So it's really the presence of tone here. And if we look at what is the usual estimate when you use the Ashworth scale, it means that the presence of spasticity would be more like 25 to 30%. Is that okay, Mohamed?
It's fine.
Yeah. Okay, if we have when I talk about guidelines, the guidelines I will use, which is the website on the bottom of the slide, the guidelines that I will use are the Australian stroke guidelines. And I'm not using them just because I'm Australian. So I'm using them because they actually are living guidelines. So they get updated all the time. And I think they are the only guidelines that I know of in the world that are being updated continuously. So I sit on two working parties. I sit on the working party for strength and the working party for standing balance. And every 6 months, we need to review all the new literature to see whether the guidelines need to change. So I think they are very clearly laid out in those guidelines. So if we have a look at what these guidelines tell us about interventions for spasticity, where there is a weak recommendation, the guideline is saying that you may do this. When it's a strong recommendation, they're saying that you absolutely should do this. So they have a weak recommendation for Botox, but with this strong note here that Botox is unlikely to improve activity or motor function. So, and this is where I was saying in the upper limb, we have very clear evidence, because there's a very big systematic review for the upper limb, that Botox reduces pain. It improves hygiene if people have a very tight hand that can't be washed and dressed properly. It can improve pain, it improves range of movement, it improves hygiene, but it does not change function. We don't have such a big, clear systematic review of the effect of Botox in the lower limb, but I'm doing one, so hopefully we will have one. We will have one, hopefully in about a year. But certainly, what we're looking at is that there's no clear indication of Botox improving walking is the first thing that we're looking at. So loss of strength after stroke is really the big thing that we need to be worried about. And here we have a man this is a tilt table that has a sliding function to it. So these tilt tables were first developed in Australia, I think, well, unless there's somewhere that I don't know about. But pretty much every rehabilitation unit in Australia has these because they're so fantastic. But what this really is showing, though, is that this man's called Mr. Lee. We have a few videos of him through the lecture, and you can see how profoundly weak his leg is. that his left leg, it's not even going to score a grade 2 on manual muscle test. It's very weak. It's very slow. He has a lot of trouble in that inner range, which we know is a big problem after stroke. He can't sustain force. This is his daughter, and she asks him to try and hold for 3 seconds, and he can't sustain force. So weakness is really, if this man needs his strength to get better for really to get any significant improvement in function. Loss of strength is quite prevalent after stroke. So this is data from the UK from 95,000 stroke survivors. And this is the percentage here. And this is the people presenting with weakness in their arm or in their leg, left or right. So if you add that prevalence together, you get somewhere in the order of 70 to 75% of stroke survivors initially presenting with weakness in an arm or in a leg, or a lot of them would be both, obviously. And really that the 20-25% that don't have weakness are probably really largely the stroke survivors that have had a very small stroke and actually leave hospital very quickly. So we have a very high prevalence of loss of strength. And this is then looking at people with disability. So in people with disability after stroke, in measurements of their affected leg, it usually has less than 50% of normal strength in all of the major muscle groups. Now, just to be clear about what happens with the trunk and what happens with the leg, where people have measured trunk muscles, there is some loss of strength, but it is not nearly as severe as the loss of strength in the leg. So if you're worried about trunk muscles, don't worry about trunk muscles.
There is no problem in trunk muscle. We overestimate there is a problem in trunk muscle. Really, there is no problem. It's a big issue in the lower limb, not front. So
Exactly.
that's why not supplying. There's no affection.
Yep, great summary. It's just, yes. So, and that is because our trunk muscles have bilateral innervation. Because we need to protect them. They're very important for breathing and things like that. So they have a bilateral innervation, whereas obviously our leg and arm do not have that. So, and this is just briefly to show that when you stimulate the left motor cortex, you get a response. So this is where they've stimulated in the left motor cortex or left in the brain, and they're measuring response in the muscles. You can see if you stimulate the left motor cortex, you get a response in the left and the right, both. But if you look at the finger, you get a response in the right finger, but not in the left. So that's just evidence of that bilateral innervation to trunk muscles. This is then looking again at some of those studies that report correlations. And what we see here is very big correlations between strength and sit to stand, strength and balance, strength and stairs, strength and arm function. And we also see them very, very big ones with walking as well too. So this is really to explain why we see such large correlations between strength and activity in people after stroke. In this graph, you can see activity is represented on the y-axis and strength on the x-axis. And what this graph is telling us is that in people with low levels of strength, people that are around here, there's a very direct correlation between their strength and their performance at the level of activity. So if you are trying to improve their performance at the level of activity, you actually need to improve strength. So if you think about somebody here who doesn't have much strength, and so their level of activity is here, then they improve in strength to here, then their level of activity is here. So because of this linear correlation. If you look at people like us, who have normal strength, and so we're up here somewhere, if we improve from here to here, it's not going to change our function that much. So, sorry, Mohamed.
It's about coordination. There is a limited line. After it, no rule in strength, but comes the coordination.
Yeah.
We need to coordinate.
Yeah. So we'll really look at a clinical reasoning model as we go through the lecture, in which we think about when people are very weak, We really need to address their strength to improve their function. If they have some reasonable strength, then we can focus much more on coordination, which is really our task-specific practice, and we'll define exactly what we mean by that task-specific practice as we go. So coordination, we're defining coordination is the loss of muscle activity needed to It's not coordinating your muscle activity as needed to do the task that you are trying to do. So beyond strength, we know that people will still often have problems with their movement because they can't coordinate that muscle activity. It needs to be switched on with the right amount of timing and exactly the right amount of spatial accuracy. So producing the exact amount of force to get to the exact endpoint that you're trying to get to. This is a study looking at loss of coordination after stroke and using something called the Lemicot. So in this test, you move your toe from one marker to another marker and back again. So you move between two markers as fast as you can. So they're testing the spatial accuracy and the timing in this test of coordination. And this was done in this study, it was done on people that had grade 4 strength. So they had some reasonable strength in their lower limb, so they could definitely move their leg, but their coordination is only 64% of normal in these stroke survivors compared to age-matched controls. So coordination is very impaired after stroke. When we think about how we address coordination problems, we think about that definition of coordination. It's about coordinating muscle activity to do the task that you're trying to do. And so we need to do task-specific practice to improve people's coordination. But I think what, as therapists, we are very skilled at doing is identifying what part of their movement needs to be really focused on. What are they really having trouble with in terms of their coordination problems, and addressing that in task-specific training. And so in our guidelines, we have a strong recommendation for task-specific training for improving all activities. Okay, now it's very late at night for you, so I'm actually going to get you to do a bit of exercise. And there is a point to this, which we'll come to. So if everybody can, you might need to push your chair back. And what you're going to do is you're going to just do stand up and sit down. Stand up and sit down. Okay, do you reckon they're doing it, Mohamed? Okay, I'll tell you when to start. Okay, are you ready? Starting now. And stop. Now, as I said, there is a point to this that we'll come back to later. Can anybody put into the chat how many repetitions they did? Did anybody count and know how many sit-to-stands they did? Oh, okay, Yara's doing a lot. So some people have counted. Okay, I think you can probably do a lot more, but I did not give good instructions, did I? You didn't know how long you were going to go for. Yes, and as Ahmed said, I didn't ask. You weren't even asked to count. So we're going to think about giving better instructions as we go. Okay. We're going to move on now and talk about sensation. Okay, so we've talked about loss of coordination, both being very correlated. Sensation is quite prevalent. So this study looks at 100 stroke survivors. And if you have a look at who has impaired or absent or intact proprioception, only 25% of them have a loss of proprioception. But about 63% of them have a loss of tactile sensation. So it's really relatively high prevalence of loss of tactile sensation. But there's no clear indication in the research done about impairments of sensation always being linked to people's movement problems. So very different to strength and coordination, which are always associated with function. And so this is a video of a stroke survivor called Jenny, and Jenny has no sensation in her right leg. So she has no tactile sensation and very poor proprioception. But you can see she's working on an obstacle course. You can see she still has some problems with her right leg. She has to look a lot, but I mean, she is going over obstacles. But, she's got some relatively good movement. And she was able to, before she was discharged, she was going up and down stairs and walking around outdoors and things. So I think the issue about sensation in the lower limb, I think it's different in the upper limb, but in the lower limb, people can learn to compensate for a loss of sensation. And you can't really compensate, well, you can just end up moving badly. You can't really compensate so much for a loss of strength or a loss of coordination. So I think if we think about sensation, we can just really do a lot of task-specific training to help people learn to get back to moving better again. In our stroke guideline recommendations, we do have a recommendation for some specific intervention for the upper limb and insufficient evidence really about any specific training for the lower limb. And also, that's really kind of unclear what difference it would make in the lower limb. I'm not going to go to this, but I've put the reference in case you're interested. It's in the PDF handout. But this is for upper limb training of sensation. And there's 2 randomized clinical trials associated with this sense training where people do very specific training in the upper limb. Because I think really it can be much more disabling if you can't feel what your hand is doing. If people do have sensory loss, I think it obviously can make a big difference, though, to the intervention, because maybe we need to give them more information. So here's this man doing some standing and he's got a left-sided weakness, and he really can't feel how much weight is on his leg. So we've got scales, and so we can give him some more information about how much weight is on his left leg. So if we have a look at the summary of this information, this is really looking at the associations. Loss of strength and loss of coordination have a clear association with activity limitations. Loss of sensation, well, a bit more in the upper limb, but not surprisingly little in the research. Spasticity, again, it has often been attributed as being a big problem, but that certainly does not come out when it's really being looked at in the research. And contracture, I think I haven't gone through that research, but again, sometimes there's a correlation, sometimes there's not. But I think for us, we know it's a big problem, because if somebody has a contracture, if you go to the example of dorsiflexion in swing, if they can't dorsiflex because they have a contracture, then that is a big problem. That will completely stop them being able to dorsiflex. So at that level of looking at specific movements, it is a big problem. So if we think about our movement analysis, then we've talked about this process of thinking about the potential impairments and being very aware of the contribution. And the big message, as Mohamed said too, somebody was saying, worry about strength and coordination. Those are the really big problems. If we think about what's critical, and then in our analysis, when we're assessing people, we do need to look at passive range, because obviously you do need to know that. If somebody hasn't got enough dorsiflexion to get dorsiflexion in swing, then you need to know that. So we could think about these as being the very critical impairments that we always need to assess, because they can have a big contribution to loss of function, and a range of other impairments that exist after stroke as being things that we need to be aware of, but we probably don't need to worry about assessing them in a lot of detail all the time unless they are a very big problem. But they will change the type of intervention and coaching that we use. And that was that example of showing the man with no sensation in his leg. Then maybe you're going to change the intervention a bit for that man and use scales and give him more information about how much weight is on his leg. Take-home messages from that section: worry about the negative impairments, strength is critical. So our analysis and training should really focus on strength and coordination impairments. Any questions? This is one of my dogs.
دكاترة، في حد عنده أسئلة جزئية؟ لو في حد عنده أسئلة يرفع إيده وأنا هعمل له ميوت. حد عنده أسئلة؟ عبد الرحمن، قول يا أحمد، هعمل لك ميوت. محمد خطيب، مؤمن، اتفضل.
طيب أسأل بالعربي ولا بالإنجليزي؟
أي حاجة اللي أنت عايزها، زي ما موجود زي ما موجود.
وأنا كان سؤالي إنه أنا معاه عيان ستروك. هو السترينث بتاعه كويس خالص، يعني بروكسيمال وديستال كالوريوم، بس الفكرة إن لما يهم يمشي بسرعة رجله بتكلبش. أنا فهمت إن الموضوع مش عارف بقى السيستم إنها فيلوسيتي ديبندنت بالكوردينيشن، ومش عارف أعمل إيه كانفورميشن. هل مشكلته في الكوردينيشن ولا في السبستيستي؟ ده أول سؤال. ثانيا أنا كانفورميشن أركز معايا بناء على السؤال الأول.
Simon Austin, he has normal strength of his lower limb. There is no problem.
Yeah.
But when you try to train him on walking, he face difficult of walking due to catch of his lower limb. What do you think about that?
Because a catch of his lower limb, is that
Catch of his lower limb?
when as he swings his leg forward
Yes.
and it catches?
Yes.
Yep.
What do you think about that this problem?
That actually is a bit similar to the videos we're going to look at because we're going to have a look at one man called Michael and have a look at his walking and the intervention for his walking. So hopefully that might be helpful. But I think if you looking at swing phase problems, you really need to look at, and somebody has good strength, how fast can they turn on their hip flexors? How fast can they turn on their dorsiflexors? Can they also, depending on the speed of their walking, if we walk at normal speeds, we don't really use our knee flexors. But if people are walking more slowly, you do use your knee flexors in swing. So probably have a look at knee flexors as well. So have a look at, if you just do, if that person just does a foot tap in sitting, can they do it quickly? Can they do it as quickly as the other foot? Looking at their hip flexion, can they do it quickly? Can they flex their hip as quickly as the other leg? If they've got strength, then you might actually be able to make a lot of difference to them by really addressing their coordination problems.
Manel?
أنا فهمته كده إن أنا أقيم سرعة الكونتراكشن نفسها، مش بس
بالظبط، ولسه تشتغل على الوضع الأول مش فانكشنال، بالوضع اوبن فاينيتك عادي، وبعد كده تدخله في فانكشن.
هو بيجيب لأن هو بيجيبها كويس أوي.
لا بس مش بالظبط.
أراعي حتة الفيلوسيتي دي أثناء الانترفنشن، صح؟ ما هو بقى هنا السؤال التاني اللي هو إيه قدر السترينث اللي يخليني أقول إن أنا أشتغل عندك كوردينيشن؟ يعني قدر السترينث اللي أنا أقول لأ خلاص العين ده وصل زي الامتحان الدكتور بقى أشتغل كوردينيشن.
Okay. Simon's second question, he asked about what is the criteria for strength to start after it coordination exercise. What is the criteria?
That's a very good question, isn't it? we actually, don't really know what are the kind of the amounts of strength that you have to be able to do certain activities. And I think really, we should be starting task-specific practice very early, even with very weak people. The problem is that task-specific practice has to be very modified in people that are very weak. So maybe if you're working with somebody who is very weak, it probably is good to start doing some sit-to-stand and standing, but their sit-to-stand will have to be from a very, very high bed. Maybe that with their standing, they might, maybe they need some assistance too if they're very weak. So I think we probably really should even start that coordination training even when people are very weak, but that most of their intervention is about increasing their strength. And we'll look at some examples of that as well too. Can I answer a question, Mohamed, from Karim Mohamed in the chat about indication for Botox?
Okay.
I can see the question in the chat bar. He's asking if there's an indication criteria for Botox. So I think that is very clear in the upper limb. In the upper limb, there's a clear indication that if people have a very, a lot of spasticity and a very curled up tight hand, that's causing problems with cleaning and hygiene, maybe causing pain and discomfort, that is a clear indication for Botox. Botox is very effective at loosening that up and being able to clean, increasing passive range of movement, improving hygiene, improving pain as well. So in the upper limb, I think we have a very clear indication that there is good times when Botox is very effective for those problems. But we just have to be very clear in knowing and communicating with our patients that it will not make their hand or work better. It will not change their function.
Most lower limb.
In the lower limb, we don't have such clear guidance in the lower limb. I think what I would say is that I would not use Botox expecting that it's going to improve somebody's walking, because it's not addressing the main problem. The main problem again is the strength and coordination problems. But if you have somebody, and I think the other thing to think in stroke it's quite unusual to see very severe spasticity in the lower limb. But sometimes if you
we have a lot of the patients have severe spasticity lower limb.
Yeah. So if you have younger people who've had a hemorrhage, I think you can often see much more severe spasticity. And certainly if you work with people with traumatic brain injury, you see very severe spasticity. If they have such severe spasticity that is really interfering with the ability to stand, like really severe spasticity in their hamstrings or their plantar flexors, then I think we don't have clear evidence, but maybe it is worth doing a trial of Botox. But I would only suggest that in very severe spasticity. And then even then there's no clear evidence that it will really change their function.
What do you think about Botox injection? After it, we can use orthosis?
After Botox, you can use what, sorry?
Orthosis? Orthosis for lower limb? Ankle foot orthosis?
Okay. I'm going to have put in a bit of a section called foot orthoses. I think where possible, we should try and avoid using them, because I think they actually, particularly Mohamed, where the ones that you use, are they mostly the fixed ones or the ones with a hinge?
Fixed one.
Yeah. So I think really, when people are in a fixed AFO, it interferes a lot with their walking biomechanics. It stops them getting into dorsiflexion. And I have no evidence for this. This is not evidence, but I think probably it helps them to get more contracture, because their ankle is always fixed at that angle and they don't go into dorsiflexion. It means that when they stand up on their leg, their foot is out in front and they can't weight bear on their leg when they stand up. When they're standing, they don't weight bear well on their leg. So I actually think an ankle foot orthoses or orthotic really causes a lot of problems. And also the compliance in, there's studies that have done looking at compliance. Often the stroke survivors don't like to wear them. So often compliance can be low. But if you have somebody who has such an unstable leg that they really, they're going, their ankle is they're going laterally on their ankle. If somebody has a very unstable leg, maybe that is a reason to give them a very rigid AFO.
There is no other options.
Yeah, but there's a lot of other options to help dorsiflexion in swing that are much better options. And I've got a section on that in the walking section. I wonder if we should keep going in the interest of time, Mohamed, because we've got more time for questions later as well.
You can take another question or another question.
Yeah.
يا دكتور
Yes, is that?
أيوة.
بعد إذن حضرتك كم سؤال مشي والأرثوزس برضه عنده.
هو سؤال عشان يعني خلينا سؤال إن الأرثوزس هتتشرح بعدين، يعني هنشرحها بعد لازم السيشن.
طب بالنسبة إن إحنا عايزين نعمل سترينثنينج للور ليمب، لو حد وصل من البيشنس إن هو يبقى بيعمل ووكينج معايا في الجلسة، الووكينج ده ينف ولا أنا أفضل أكمل إكسرسايزز تاني مع الووكينج؟
الووكينج بتاعك يعني مظبوط ولا في مشكلة؟
يعني يتظبط بالكين بس، لأن البيشنت كان حصل له وقعة وكان
كويسة ولا فيها مشكلة؟
بيبقى فيها بلانتر فليكشن زيادة، فبنضطر نلبس الإفو علشان نثبت رجله.
وأنت حاولت إن أنت تعمل ستريس للدورسال فليكشن؟
لا، حاولنا كتير، الصحية سيئة وكلاش قطع جلسات، فمفيش انتظام قوي يعني.
كمان هتلبس اف وهي لسه قايله مفيش اوبشن غير ان احنا عشان نمنع الدرينك بتاع الفوت لازم نلبس اف حتى لو ده اخر اوبشن.
الفكرة بقى دلوقتي احنا في المشي هو درايس، هل زيادة الووكينج كويسة ليه ولا لا؟ برضو احاول اتارجت الكوادريسبس وحديها، الهامسترنج، اكمل ووكينج ولا اعمل يعني اكسرسايز ايزوليتد؟
انت فينا تشتغل على كل مصل الستريس بتاعها وفي نفس الوقت انت بتعمل الفانكشن او الووكينج. ما هو الووكينج ده هو الانتجريشن بتاع اللي يعني في الليمب انسات في الاخر ما عملتش الفانكشن بتاعت الليمب.
تمام. طب والتايم والريبيتيشن يا دكتور؟
ده هنتكلم عليه في اخر السيشن. اوكي، اللي هو الفوكس بتاعك على الانترفنشن. اوكي
تمام.
Did I keep going, Mohamed?
Simone?
Questions according to type and timing and exercise loading. You mentioned that functional exercise as set to stand and individual muscle strengthening and agonist and antagonist coordination. There is dilemma about the exercise type. That's the first question. The second question, to how extent I can accept compensations.
That's a good question, Manal. I will be showing you quite a lot of photos and videos of certain types of exercises. I think we can kind of divide exercises into just plain strengthening, like isolated strengthening exercises. And there's some examples at the back of your lecture handout where you've got a very weak muscle and you're just working on one muscle group in isolation to increase strength. So there's just pure strength exercises. And then our other exercises really should be some type of task-specific practice. And I'll show you some examples of task-specific practice for people that are very weak compared to people that are stronger. And how much we should accept compensations is a very, very difficult question for us, I think, because we should never stop people practicing. Because if we stop people practicing, they certainly don't get better. So I think we always need to allow some way of people starting to do some exercise or to also include some task-specific practice. And sometimes there might be some compensations, but I think we should always be trying to make it the best quality that it can be with the impairments that people have. So I think that it is a very difficult line to draw. And I think we will talk a lot about amounts and intensity of practice. We need to set up ways for people to practice when we're not there and for people to practice without us. So we need to think about how do we try and make that the best quality it can be. And so we're going to look at ways of sort of trying to think about how do you force people to have weight on the affected leg, force weight bearing, and try and really make the affected leg to work hard as possible, to limit the compensations that people have of just taking all the weight off the leg and using their hand and things. So we will look at a lot of examples of that. But I think we do need to set people up to practice, but just to make it as best as it can be. I really think I probably should keep going, Mohamed. I'm going to get... I'm just getting a bit worried because I'm sorry. I know there's lots of questions, which is fantastic, but I do want to make sure that we kind of get through the content as well. And also I think the content might answer some of those questions that are coming up. So what we're looking at now is, what do you do about strength? We've just identified that strength is a really very, very, very big problem. So what do you do about strength? So this is really thinking about muscles that have less than anti-gravity. So it's a grade 0, 1, and 2 of strength. This is in our stroke guidelines recommendations for electrical stim, for just doing isolated movements, and for task-specific training, which obviously will be very modified if people are very weak. So if we look at some of those, we start with electrical stim. So thinking about, using it on big muscles as well. So here somebody is using electrical stim to help to get their hamstrings stronger. And maybe that would be, and if you had trouble with that working, you could use bigger electrodes and 2 channels on the hamstrings. Here's somebody using electrical stim to their dorsiflexors. But you can see what we've done here is still have some targets for them to try and use, because I think, obviously when people have very, very weak muscles, the principles that we are needing to follow is that we're trying to increase central recruitment to the muscle. We need to get neural plasticity. So the dosages of practice need to be very high. People need to be doing a lot of repetitions if they have very weak muscles, because we need to get more central recruitment to those muscles. So if somebody's doing electrical stim, then they should be really set up so that they're working with the machine, that you're really trying to get them to focus and concentrate. And so here the idea is that person, is really trying to work with the machine. So you put the same cues and targets in that you would in any type of their practice. Okay, so In the back of your lecture notes, there was a PDF document. So I'm just going to switch to that quickly. Is that showing okay? Sorry. Yeah. This is, so at the back of that document, you have some examples, but you can see the principles. Is that showing okay, Mohamed? That you're seeing the strengthening exercises? Yeah. So the principles here, you can see for every exercise that somebody has been set up to do with very weak muscles, the principles are that these are exercises the therapist does not need to stay with the patient. Okay, so you have external cues, visual cues, guiding the movement. This man, to change strength in his leg, he needs to do hundreds and hundreds and hundreds of repetitions. So it needs to be set up in a way and practice without the...
Simone, again, what is the amount of repetitions?
We don't know the magic number, but what we know is for neural plasticity that you need to do hundreds and hundreds of repetitions. It would be very nice. It would be very nice to know the exact number. Imagine if we could say you need to do 300 repetitions a day, and that will take you from grade 1 to grade 2. But we don't have an exact number. But we know that it needs to be a lot of repetitions. I think some of the other principles we need to think about is that particularly when it's knee extensors, is that it should be closed chain. The idea of pushing down into your foot, it really gets people much better to activate their knee extensors and also their ankle plantar flexors. And so this person here is pushing into scales. This person has got a sphygmometer cuff underneath their knee. Because also, if you're going to leave people to practice by themselves, then if they've got something that gives them some feedback, then they're going to do more practice. Mohamed was saying that you often have tilt tables in Egypt. So I'm assuming that you just have this type, the fixed one, and not the sliding one. Is that correct, Mohamed?
Not the style of tilt table, but near to that, not the exit one. But near to it.
But this kind of one, this one is just a plain, doesn't slide.
Not all have that type of tilting.
Yeah. So if you have this type where just a fixed tilt table, but you can tilt the back of it, then just moving from flexion to extension, but targeting the weak by itself, holding the weak leg straight while you move the other leg, knee flexors, then ankles. So just some ideas there. Really, so I won't spend a lot of time on those because you have those. But you can see the main principles of using external cues, setting the exercise up so that it's semi-supervised or independent. It doesn't have the therapist there all the time. Okay, I'm just going to go back to So this is, again, the sliding tilt table, which is, obviously a much easier version. But again, you can see the main principle here is that this man is practicing with his daughter. So the therapist is not there. The daughter is supervising the exercise. And this is the one on a fixed tilt table. This is a woman at home. Oh, the video's gone a bit funny, but she's got a serviette kind of thing so that she can practice using her knee flexors. So thinking about the kind of things that you've got in a home setting if you're seeing people at home. And again, she's set up so she can practice without a therapist. She just needs some targets on the floor to do her practice. This is the same lady, but she is in an apartment block. And in the apartment block, there is a small gym. And so this was a very good setup for her using a leg press in the gym in the apartment. So thinking about if there's other sort of equipment that can be used. And then task-specific training, we know that if people with very weak muscles do task-specific training, that will also help to improve their strength. So here you see Mr. Lee. Again, he's working with his daughter. So he's in the physio gym, but the daughter is supervising his practice. And for him to do this sitting and his reaching to his affected side, he's going to have to really use his lower limb extensors here to do that practice. So that task-specific practice will also help to increase strength.
So Simone, this task not stress on trunk muscle, but on lower limb.
Because when you think about what will stop him falling in sitting,
lower limb.
is his leg muscles. His trunk muscles will just make his trunk straight, but they won't stop his trunk from falling, because they don't cross the hip. So they can't bring him back into upright. So it really is about his leg muscles. And here, can you see somebody who's very weak? So you can see his leg is very weak. And he's practicing standing, and this practice will probably have some benefit also for helping to strengthen his leg in that very weak leg. You can see it's very, very hard for him to do because he has very severe weakness at this time. In our guidelines, we have a strong recommendation for progressive resistance training, but progressive resistance training is our very classic strength training, where you do 2 to 3 sets of 8 to 15 repetitions maximum. So you're pushing against an external force. So really, you can only do progressive resistance training if you have enough strength to push against an external force. So you need to have already a grade 4, if you think about it, really a grade 4 in your strength, but you might be able to do it with grade 3 in the middle range of the muscle. So we do have a strong recommendation because there's clear evidence, and this is a systematic review that I did, there's clear evidence that progressive resistance training does change strength. It's a large effect size, an effect size of about 1, which is a statistical value, but it indicates a large effect. But if you have a look, this is the effect of progressive resistance training on activity, and you can see the effect on activity is non-significant. It crosses the 0 line, the line of no effect. So there's quite a variety of outcomes for activity, but it doesn't necessarily carry over. So this large change in strength does not necessarily carry over at the level of activity. And it's because when we go back to that graph, if they're strong enough to do progressive resistance training, then to improve at the level of activity, you need to address their coordination problems. Is that clear? Okay, Mohamed, do you
It's clear.
So from
I will translate what you call. Okay. دكتور سيمون بتقول ان هو وانس ان احنا وصلنا لاباف جريد 4 تمام. فاحنا الاثر يعني اللي هيجيب معانا اثر شويه او اللي يحقق احسن استفاده للعين هو التاسك اورينتد او الفانكشن نفسها عشان نحسن الكوردينيشن. ومعنى كلمه كوردينيشن هي باينه، مش معنى كلمه كوردينيشن بالمعنى اللي احنا عارفينه زي بتاع الاتاكسيا، لا هو ان انا ازاي اطلع البروجرام والكوردينيتد. فبالتالي يعني كاني ده افضل فانكشن تمام. فده مش غير ان احنا نعمل فانكشن سترينث مني كونتينيو سيمون. اوكي.
So we have take-home messages from that section. Strength is critical in people with very weak muscles, and by very weak I really mean the 0, 1 and 2. Concentrate on increasing strength, and actually any increase in strength will usually carry over to improved function because they're in that part where there's that linear relationship between strength and activity. In very weak muscles, the dosage is hundreds, thousands of repetitions because you're aiming for neural plasticity. In stronger muscles, i.e. grade 3 and 4, they're still not normal strength. So it's still a good idea to get them stronger, but you need the task-specific practice that changes coordination to get more carryover in their function, to improve function. I don't know if we do we want to stop for questions or do we want to keep going? What do you think, Mohamed?
Keep going.
Keep going?
Yeah, keep going.
Okay. Well, we're going to wake everybody up in case you're getting sleepy late at night there. Okay, so I gave you a very bad instruction last time. So the instruction was to do some sit to stand, and you didn't know how long. You did not get asked to count your repetitions. So this time I'm going to be a better therapist and give you some better instruction. Okay, so you're doing 20 seconds, which is the same as last time. You're doing 20 seconds of sit to stand. So push your chair back and count your repetitions. How many do you do in 20 seconds? Okay, I'll just set my stopwatch. Ready and go. Okay, can you put your number of repetitions into the chat bar?
10 times.
Okay, so I think on the whole we're getting better numbers. I think we can still probably get more out of you. So next time we might think about an instruction that would actually make you work harder as well. Okay. Now we're moving on to task specific practice. and really combining these two things. So what's the clinical reasoning process around our delivery of effective task-specific practice, and also talking to some of the evidence for effective training of lower limb skills. So we talked about this graph here, this linear relationship that you have between very weak muscles and the need to increase strength when people are very weak, and then to address coordination problems more as they're stronger. So this is a kind of a model, I guess, that you can use. So if you think about paralyzed and very weak muscles, the 0, 1, and 2, that strength training needs to be a very big focus of intervention. And you can probably do some coordination training, but whatever coordination training you do is probably going to be very modified anyway, because people are very weak. So, and again, we'll have a look at some examples, but like the Mr. Lee, when he's very weak, and you can see he's still doing some sitting and reaching practice, and the other man doing the standing practice. It is starting to do task-specific practice, but it's limited. When people grade 3 and 4, then again, you can, still work on strength, but probably the very big focus of intervention is more around coordination, which is your task-specific practice. I'm just going to illustrate this with these videos. So if you have, this is the same man. This is him. He's a man called Vinko, and here he is walking early after his stroke. You can see he has very extreme weakness, and you see his leg collapses here. The therapist has to pull his leg through for swing phase of walking. So you can see he's got very extreme weakness. And at this point in time, his performance is not going to change unless he gets more strength. So at this point in time, the biggest focus of his therapy is to increase the strength in his right leg. And you can see he's really quite, a lot of assistance from, this is his daughter and one of the physios with him. But you can see he's got very extreme weakness here. Now, this is Vinko now a month or two later. And so now you can see he's got much better strength in his right leg. He probably would still benefit from strengthening work, but now the focus of his practice can be much more around his task-specific practice to address the problems, that he's still having, with he's got very slow dorsiflexion, slow hip flexion. He doesn't shift his weight well onto his right leg in his stance phase. He's still got problems with his knee control. So he could now, really the focus could be much more on his part practice and his walking practice to address those coordination problems that he's having. So what are the really critical features of doing effective task-specific practice is that we need to be very clear on our biomechanics. And that's why I think it's also very important for us to understand things like, when we're sitting, the main muscles that can stop us losing our balance in sitting are our leg muscles, not our trunk muscles. We need to have a very clear understanding of the normal biomechanics. And when we set up people's practice, that we try and reproduce those biomechanical demands in that practice to make the practice as effective as possible. So what are the muscles that are working? What are the kind of joint angles that they are working in? What types of contraction are they performing? What's the kind of the timing of that muscle activity? And when we set up people's practice, whether it's their whole task or their part task, like a component of the task, we address those biomechanical requirements. So we're going to have a look, and we're going to work through this man's walking problems and think about what kind of practice he could be doing for the main problems he's having with his walking. So have a look at his walking. So you can see it's not too bad, but he still sometimes loses his balance. So he still walks with somebody next to him. He's got some quite specific problems with his swing phase that you can see there. And we'll also have a look at him from side on. I might pause that one.
And on the very inside.
So when you see him side on, you can see He's missing a little bit of knee extension, sort of missing hip extension, missing some hip extension and push off. He doesn't really shift his weight laterally onto his leg. In his swing phase, he's missing some hip flexion and some dorsiflexion. He doesn't have a heel strike at landing. He just lands on a flat foot. So if we make a list of his problems, those are probably some of the main problems that he has. Are you happy with that list? If we work on that list, that's the list I made. Though I think we probably should put something about his knee into that list as well. But we'll kind of work through and think about these problems. So if we have a look firstly at the decreased hip flexion in swing, we know he's already got probably just about a grade 4, a grade 3 to 4 in strength of his hip flexors. But if you have a look, this is his left leg doing rapid hip flexion, and this is his right leg. So can you see that if you have a look at the coordination of that movement, it's quite poorly coordinated. So if 10 reps takes 9 seconds for his left and 12 seconds for his right. So if we think about setting up some task-specific practice for his hip flexion in swing, what I've done here is put him on a block, because otherwise his ankle stops him being able to, because he can't dorsiflex well. So he's doing some practice where he's really trying to work on getting that rapid hip flexion, starting from extension, going into rapid hip flexion. Now, I think there's actually a couple of problems with this exercise, because remember, at the beginning we were saying we need to reproduce the joint angles when we're setting up the practice. And so it's actually too much hip flexion. Really, we only go into 30 or 40 degrees of hip flexion in swing phase. So it's a bit too much hip flexion. And I think probably too, he needs a soft landing, not the hard edge of a table, because we're trying to get him to go quickly. So he would be better with a softer cue. So there's some improvements we could make to that practice. But you can see that, he can practice and he can do lots of repetitive practice. You could time him because you're trying to increase his speed. Do a set of 20, Michael. We'll see how long it takes you to do a set of 20. Now do 20 again and see if you can go faster. He would probably be quite safe to practice on his own. He can hold on to something because it's not a balance exercise. It's an exercise for his swing phase. If we look at his decreased ankle dorsiflexion, so again, just comparing his left leg and his right leg. So that's him trying to do, and so you can see he doesn't really even have a full grade 3. He's quite slow. And then if you have a look at his intact leg, that's his normal dorsiflexion. I'm kind of laughing because it looks so different. So what we did there was have a look at how many reps in 10 seconds. On his left leg, he can do 3 repetitions. On his right leg, he can only do 12 repetitions in 10 seconds. And you can see also that his range of movement is not very good there, his active range. He has full passive range at this point. So when we think about addressing his dorsiflexion in swing, we've set up an exercise for him where he's really trying to get a heel strike, and he's moving from some plantar flexion and holding his dorsiflexion when he lands. He's going over a small obstacle, but if we put a big obstacle there, it will just make him use a lot of hip flexion. So he's just going over a small, so that if he doesn't pick his foot up, he might just kick the ruler, or it's a goniometer actually. He might just kick that a little bit. So it's giving him some feedback there about that. And then again, he could do this on practice by himself, and he could do timed trials of this. Okay, so what else can we do about decreased dorsiflexion? Well, as I said, if, for somebody like Michael, I think there's definitely no indication to give him any sort of device, because he just needs to do a lot of practice, and he will be able. With a lot of practice, he will get pretty good dorsiflexion in swing. In our guidelines, there is a weak recommendation for ankle-foot orthotics, but we also know that people have very low compliance with them. And as I said, I think they really interfere with people's ability to weight bear on their leg. So I think if you can use some other kind of device, like this is a Sabo device that helps to hold the foot in some dorsiflexion. This one is one that we use a lot in Australia called a dictus band. And you can see there's a version that can attach to a shoe and a version that can be put on the foot if somebody wants to walk barefoot, around their house when they're at home, that you can have a version for a barefoot. I've left this here so you can have a look at this if you like, but this is a electrical stim device which works very well. It just stimulates at the perineal nerve, and it'll have some kind of sensor so that it knows that to switch on just in the swing phase. Those devices work very, very well, but they're very expensive. And so in Australia, really many people would not be able to afford that device unless they've got unless they're covered under some sort of insurance scheme or something. Okay, so if we keep going with Michael and have a look at his other problems, at his stance phase problems, he doesn't shift his weight laterally over his right leg. He doesn't get hip extension in stance phase. So here we're looking at, so you can see he can actually weight bear relatively well, just going in and out of single stance on his right leg by making him do a foot tap kind of exercise. He doesn't shift his weight laterally very much over that leg though. So in this next one, now to make him safe, we've got a therapist next to him, and now we're asking him to come across the block, so he has to shift his weight laterally. And you can see that's quite hard for him to do because he can't, work his abductors well enough in combination, with his extensors. So you can see for him to be able to weight bear on his right leg, he needs to do things that are a bit more challenging for his single stance. So this would be obviously for safety better for him to do this practice as a one-to-one practice with a therapist. And you can see now also we've marked where he needs to come back to, so that he needs to maintain a sort of he can't put his left leg back into such a wide base now. And so that's also quite hard for him. So this would be very good practice, probably to help improve his weight bearing on his right leg. And then then you could also start to move the block further away so that he also starts to get more hip extension as well as the hip adduction over that leg in stance phase. Now the last one that we've got on the list here is his decreased push-off, his decreased plantar flexion in late stance. And here he doesn't have enough strength in his plantar flexors to really do any task-specific practice because they're still too weak. So for this exercise, he's basically just doing strengthening. So he's on a sliding tilt table. You can see it's at quite a low angle here. So again, you could do this on a fixed tilt table with somebody having a slide sheet underneath them. But we need to increase the strength of his plantar flexors in order for him to start to be able to get some push off. And then when he's got more strength, he could go on into some more task-specific practice. If we think about what actual walking practice would be useful for Michael, we think about trying to increase his step length, increase his speed, then cueing of cadence. If he walks to a metronome would probably be quite useful. Using a treadmill, but maybe with two very different aims. So you could use a treadmill to improve his swing phase if you put him on an incline and increase the speed. So he really has to flex his hip and get his dorsiflexion very quickly. Or you could also use it, maybe not so much working his swing phase with it flat, but working on trying to get a better step length, get into more hip extension. So I think a treadmill could be quite good for his whole practice as well. But he could also just do lots of practice just over a floor, but also maybe counting his steps. So he does bigger steps. Or using the cueing, where people walk to a metronome and you increase their cadence and then they take bigger steps as well. So I haven't got an example of Michael, but this is the lady that you saw doing the leg press. Oh, sorry, do once. 0.9 kilometers per hour. 44. I'm sorry, the video is doing something a bit funny there, but so I'm just going to see if we play it here. No, it still doing 0.9 kilometers per hour, 44 minutes per minute. But you can see she's using a metronome, but she's actually using a metronome to slow down her steps so that her steps end up being a bit longer there, and it's working her swing phase quite well too. Okay, we didn't have any really look at knee control with Michael, but Mohamed had said that there was questions about knee hyperextension or genu recuvatum. Is that? Oh, yes.
The reason is these which are very important.
Yes, it's such a big problem after stroke, and I think part of the reason it's a big problem is we know that people have a lot of trouble in the inner range of their muscles, and we are all weaker in the inner range, in the very short range of our muscles, but that problem is much worse after stroke as a proportion of the total strength of a muscle. It's much, much weaker in its inner range. So we have a problem with inner range quadriceps, but I think too, if we think about the muscles that are helping to extend this last bit of knee extension, your plantar flexors contribute. If you're about to go into hyperextension, your hamstrings probably contribute by helping to stop you hyperextending. So you have 3 very large 2-joint muscles, and you have this poor little knee. Think about you've got 2 big sticks. You've got this poor little knee in the middle with all these very big forces. So it's a very big coordination problem as well. So this man here has got his back against the wall. He's got his intact leg on a block to help keep weight on his leg. And then he's practicing moving from extension into flexion just in that small range to work on his, to work on his knee control. So he's really, and you can see, again, he's been set up so he can practice this. This man's at home. You would be able to find a way of him practicing at home where he can do it safely by himself as well. So that's really just working on just that inner range of knee control. Now what he's doing here is he's now just really trying to, and having the wall behind is very good because it will stop him going into hip flexion and give him some indication that he really needs to maintain that extended position. And now he's stepping his intact leg on and off the block, but he's maintaining his knee extension while he steps his intact leg on and off the block. So that's probably a bit more like than stance phase of walking. It would probably also be good for him to do some practice where he's then moving his weight forward and not hyperextending. So he's stepping his intact leg forward and backward as well and not hyperextending his knee. So again, he might need to have some cues to help him with that practice. And this, when you've got somebody who's really still is weaker, then this lady, Jill, was one of the things that she was working on was her knee hyperextension. So again, using this leg press machine, she's able to really work on that inner range of her knee extension to help her get more strength and coordination there. Okay, so I was going to just now go through and think about some training for sit to stand and standing in people that are unable to sit to stand or able to. So like looking at different levels of weakness. But I wonder if before I sort of move on from the problems that we were thinking of with Michael particularly, whether there's any questions, whether we pause here for questions, Mohamed.
منال عندها question بس أنا مش فاهمه بصممي في unmute يا منال.
When you're training on speed, the video that you order the patient to how many repetition he do in 1 minute or 2 minutes, this speed could be interfere with spasticity or it's safe?
No. I think we need to think, Manal, about the coordination requirements are for speed. And also, I think there has been some beliefs that if you make people do very effortful exercises, if you make people do resistance strengthening, make people work very quickly, that you increase their spasticity. There is no evidence that doing effortful, fast, working against resistance, there's no evidence that increases spasticity. So I think you just need to push them at the level of this is a coordination problem and you need to improve their coordination. And actually I think it's not such strong evidence, but particularly in the resistance, because when I did the review of progressive resistance training, some people did measure spasticity. If anything, on the measures of spasticity got better people. So I think sometimes that we don't have enough really clear evidence here, but I think sometimes when you really work on people's strength and coordination, it can actually help to decrease their spasticity. But that's not very clear evidence. But I certainly don't worry about it. Don't worry about it increasing spasticity. I think what you might see when somebody's working very hard is that you might see more discoordination. You might see more excessive muscle activity because they are not very skilled. But I think you might see things that actually are not spasticity too, that sometimes people think they are spasticity. But remember that excessive muscle activity, or people starting to use more compensations and things, that's also part of the fact that they're not skilled at doing the activity as well.
Muscle activity will affect spasticity with good effect, but will target the spasticity here will not affect the spasticity.
No, I don't think.
Not in progressive resisted training. In coordination training, it's safe.
Yes, it is very definitely safe. Very definitely.
As we understand, Simon, you talked about we can use the fast exercise training after early stage of recovery, not at the early stage.
Yes, yeah, any stage
Yeah.
of yeah. And there's a man researcher called Gavin Williams based in Melbourne and in Australia. He does research into ballistic strength training, he calls it. So people really doing ballistic movements, really, forceful lots of jumping, plyometric kind of movements, leaping and bounding and hopping and stuff. He does it in stroke and also, but more predominantly in traumatic brain injury. And it's the evidence is clear that it is improving people's mobility. So it's really very fast, forceful contractions, and it's improving their mobility. It's only very safe. Shall I keep going, Mohamed, or do we have some more questions?
Yes, I have one question. First question here. What are the requirements to start the HIIT training? If there is any requirement or criteria to start the HIIT training or not?
Or just for starting training? Any training?
HIIT training, yeah. What is the criteria to start the HIIT training?
I wasn't sure, but the sounds a bit unclear, but is there a word before training? Was it a type of training?
Yeah. What is the requirement to start HIIT training?
HIP training?
Open.
Oh, gait training. Sorry, that's the word I was missing. Gait training. You start anytime. I think the problem, if you're working with somebody, I might just go flick through and think if you're working with somebody we will have a look at these videos. If you're working with somebody like Vinko, this is the man we saw him. This is when he's very, very weak. At the moment, the only way he can do walking is with assistance of two people. So I think you can do some of that gait training with him, but it's very difficult to do it when you need assistance of two people. If you have access to a treadmill and harness system, then we have very clear evidence that when people cannot walk early after stroke, treadmill and body weight support is very effective. So the best gait training for this man would be treadmill with body weight support. But that depends on whether you have access to one of those systems. So if you've got somebody early, very weak, then definitely do gait training, because it's just trying to figure out how you can do it. The best system for somebody like this is some kind of a assisted body weight support system. If you haven't got that and you've got two people that can assist him, then that's still worthwhile. But then I think the main focus probably still really should be about getting his legs stronger, and that most of his intervention is increasing strength, and just a smaller part of his intervention is the task-specific practice. But you can start gait training anytime. Our indications are that we should not start doing any intensive training within 24 hours of a stroke. But really, I think in reality, mostly you can't get near a patient in the first 24 hours. Can you? I don't know about in Egypt, but in Australia, in the first 24 hours, they're off having scans and tests, and they're you can't at a practical level. But we are meant to start to get people out of bed and start to exercise within 48 hours of the stroke. So we are meant to start very early. But, if they're very disabled and they can't walk, then we might be starting just with some sitting balance and some leg strengthening. And then maybe over the next few days, then we might start to do some treadmill and body weight support in that first week after their stroke. So we would start pretty early. Shall I keep going, Mohamed?
Okay, I have another question.
Yep.
Hello.
Hello. I want to ask about strength training in the early stage of recovery. So I think that you prefer to strength training rather than facilitating the movement, right?
Yes, I just missed the word, Mohamed, that you're using. What type of training?
Progressive resistance training rather than only facilitating the movement. So if I'm working on the lower limb, I will work for progressive strength training for a group of muscles rather than facilitating the movement for the whole limb, right? Am I getting that right or not?
I think it's maybe just the term around progressive resistance training is just to increase strength and can only really be done in sort of grade 4 muscles. But if you're thinking about the strengthening more broadly, and we looked at those examples of setting up strengthening for very weak muscles, it is about people. I think this is what you're asking, but tell me if I'm right. It is about people actively doing the exercise and not us not facilitating. No. There is no evidence for facilitation of movement, and there is clear evidence that bow bath therapy is not effective therapy. We have 2 systematic reviews, one in the upper limb and one in the lower limb, that show us that task-specific practice is much more effective than bow bath therapy. Is bow bath therapy used in Egypt, Mohamed?
Actually, yes.
Okay, well, stop. Just stop. Because it is not an effective type of therapy. Okay, we need to set up ways for people to actively turn their muscles on, and they need to do very large amounts of practice, which also means at a practical level, if we're facilitating things, then they can't do enough practice.
It's a no-facilitating approach.
So, more question, please. So, if I have my patient with a stroke within the first early stage of recovery, I will work with progressive muscle training on the most weak muscle groups, right?
It's just the word that you're using. The progressive resistance training is putting against resistance, and if they're very weak, then they're not doing that type of exercise. They're usually doing that. If they're very weak, then it's usually more about not pushing against resistance, but finding ways like going back to these kind of exercises. If somebody is very weak,
yes, okay,
those kind of exercises will be the type of thing that they can do. If they have grade 4 strength, then you can do progressive resistance. Yeah.
Okay. Thank you.
That's that very classic strength where you're pushing hard against big resistance, and a very weak person can't do that. Yeah.
Thank you.
درست قبل هيك نرجع سبسل سيمون نور ارفع ايدك عشان بس اعمل لك unmute نور ارفع ايدك بس عشان اعمل لك unmute نور اوكي سيمون keep going.
They get shy. Okay. So just looking at, I didn't want to leave out sit to stand and standing. So we're just thinking here about, here we have a man who can't stand up independently. The evidence that we have for somebody who can't stand up independently is to do, if part of their problem, and you can see he doesn't get enough hip flexion. Okay, so here he's just doing some part practice that works on hip flexion. But we're following that principle about him trying to reproduce the kind of the joint movements and reproduce that first part of sit to stand. So he's very rapidly going backwards and forwards to touch the table. trying to get lots of hip flexion to improve his sit to stand. He's also reaching across here towards his affected side, because reaching towards his affected side will make him get better at starting to put more weight onto his left leg here. And this is somebody who can't sit to stand independently, so he's practicing with a therapist. But you can see the way that this is set up is he's got a marker on the wall that he can use to tell him to come into more hip flexion. And he's also set up so his intact side is near the wall and the therapist is assisting a bit. So not really facilitating, but just some manual assistance if he needs a bit of help with his extension, more as a safety kind of thing. But he's coming up from a very high plinth. So he's doing some task-specific practice, but it's modified so that he's not pulling up with we're trying to make sure there's weight on his affected leg so that it's to try and make the practice as effective as possible. Now we have somebody, this is Mr. Lee again. So here he still has trouble from lower heights, so he could still be doing some of this other practice, but he's also practicing here with his intact leg on a block, and that's a way of just, again, trying to increase the weight that's on his left leg. So just thinking about some ways for people that can stand up so that you're forcing more weight onto their affected leg, which is very good strengthening for them too, because there's big strength demands of sit to stand. Here we have somebody who's unable to stand. So he's practicing standing with assistance, but again, you can see he's got his affected side his intact side is near the wall. Joe is giving him as little assistance as possible so that he really has to work on extending his right leg. And you can see when he doesn't maintain extension of his right leg, he starts to fall away from the wall. And then Joe says, you need to push through your leg to push yourself back towards the wall. So it's a way of setting up for him to do some task-specific practice when he does have a lot of weakness in his right leg. And you can see he's actually really having to use his extensors and his abductors as much as he possibly can. If he was having a lot more trouble with maintaining hip extension, you could put the table up higher. That's kind of just, you could have the table up higher to give him more cues to come forward into more hip extension. And now we have somebody who is able to stand, but is doing an activity to make her weight bear much more onto her. So her affected leg is her left leg. So you can see she's doing something much more challenging to really increase the loading. And here we can start to think about what are our general principles for improving balance. Okay, so I'm going to ask you to do something. I'm going to ask you to stand up. Okay, so if you can stand up and think about, so when we're trying to improve somebody's balance, now we have a lady who can stand but has poor balance in standing. The principles of improving balance are we do things that challenge her balance. Her balance is being challenged. You can see the therapist has to catch her a bit. The principles for us, if you want to start to challenge your balance, what would you do? Because there's 3 big principles for challenging balance. And so we're identifying them. What could you do to start to challenge your balance?
I think to use the other limb.
Yep, exactly. One big rule, don't use your arms. If you hold on, all too easy. But also, in order to improve balance, you need the muscles in your legs to work and do the work. And if you're holding on, it'll be the muscles in your arms, your hand and arms that are working. So if I start to challenge my balance, the first thing I'll do is I'll go onto one leg. So effectively what I'm doing is I'm making my base of support more narrow, reducing my base of support. And that's what we're doing with this lady here. We're putting her into single leg stance. So she's now going into a much reduced base of support. And then the next thing that she is doing is she's then doing things which make her have to start to move her center of mass around more. So she's lifting her intact leg on and off the block. So I didn't write them into the slides because I wanted you to think about them, but the 3 principles for challenging balance to improve people's balance, to reduce the base of support, to do things that make you move your center of mass around, because that's what balance is. It's being able to control movements of our center of mass. And the third principle was the one that Mohamed mentioned, which is don't use your upper limbs. Okay, so don't use your upper limbs, because then you won't be turning on your leg muscles to help to make you balance. So that's sort of ideas for somebody who's more advanced. Okay, so we're going to do this is our last lot of 20 seconds. So remember, you had a very bad instruction where you weren't given any proper instruction. The next one was we're going to sit to stand for 20 seconds and count your repetitions. What instructions could we use then to make you work even harder? Does anybody want to write something in the chat about an instruction that would make us work?
You ask about...
Okay, we're doing the 20 seconds. Ah, yes, okay. So Noor is going to give somebody $100 if they work hard. Are we going to hold you to that, Noor? Okay, so maybe should we just say that we'll just give the clap to the person, unless you want to chase down Noor and get your $100. But shall we see, we'll make it a competition. Who can get the biggest one? And I'm sorry, I just realized in the chat that people had put some good ideas about the balance there that I'd missed. Okay, so 20 seconds, get ready to go. And we're going to see who's the champion. Who gets the most. Oops, sorry, just need to set my watch. Okay, halfway. Come on, go. We need to find the champion. Go. 2 seconds left. Stop. Okay, so who is the champion? Who got the most? Oh, I think there's going to be more than 11 from people. And did you do more than last time? Oh, 6. I think maybe you're getting tired. Is it getting too late? 15. That's more like it. 20. Good. Okay. Oh, Dr. Rafi, what's going on there? Oh, okay, Yusuf. Okay, Yusuf, if you did 100, then you definitely need to chase down Noor for the $100. Okay. So you can see, but the whole point of that exercise is that we need to think very much about what we say to people when we're setting up exercise for them. What we're talking about now is strategies to increase intensity and amounts of practice. Because, even if we set up the most beautiful, fantastic practice, if people do 20 or 30 repetitions, they are not going to get better. This is about neural plasticity. People need to be doing hundreds and hundreds of repetitions. So we need to think about how we change the amounts of practice. And that is setting up practice that is not one-to-one with the therapist. So by semi-supervised, I mean practice that takes place like in a therapy area. So there is some distant supervision. And independent practice that takes place at home where there's really no supervision at all. We need to empower people. We need to teach patients that they can practice without a therapist, that they can practice without us. And under intensity of practice, if we count, we record reps, we have targets, then we can do a lot to change how hard people work and change their motivation. So having classes and groups, having open gyms where families come in and help, where you use the environment set up, maybe workstations or devices. We know that circuit classes are very effective for improving mobility after stroke. And it's really because people go in and they do lots of different workstations, and so they get some reasonable effects of doing that more intensive practice. This is an example of a circuit class at a hospital in Sydney. So you can see you've got 2 stroke survivors practicing by themselves, and then they'll swap and do some other types of practice. There's a young stroke survivor here. Oh, sorry.
Give me some advice. Yes, Simone?
So just trying to get that last video to play. I can't get the last one to play. Anyway, what you see here is a young stroke survivor. Oh, there she goes. So she has a therapist with her because she's doing something that's more unsafe. But you can see the other people in the class are practicing by themselves. But they're set up for the environment to make them safe. So they're near a wall and they've got chairs and beds near them to make them safe. Having families in the gym, so having families helping to assist. So this man, Mr. Lee, had had a very severe stroke, and all his predictors of outcome would have been that he would have a very poor outcome. But he walked independently, and he walked independently because his daughter and his son were in the physio gym all day helping with his practice. If he'd only done the practice with the therapist, it would have been maybe 40, 45 minutes a day. But because his family were there, he would have been in the gym often for 4 or 5 hours a day. This man, who's very disabled, really can only be left on the tilt table doing stuff because his family are supervising him. This wife supervising her husband, this wife supervising down in the hospital bedroom, setting up exercise in the hospital bedroom. And you can see in all of these, the environment is set up to guide the practice. So when we looked at Michael before, these are all exercises that he was doing that he could do without the therapist. So he was an inpatient in a hospital at this point in time, but going home fairly soon. So he can be set up to do all these exercises by himself in the rehab gym, and then some of them he could be shown how to set them up at home. This one, when he's doing the easier version, and then he does the more difficult version when he's got the therapist. So he's set up for safety and also for effectiveness by having the cues in the environment. Any sort of workstations or devices that help. So things like the tilt tables or sliding tilt tables, people can practice by themselves. This lady's playing a computer game. This person doing their knee extensor strengthening, but with some feedback. And that obviously helps with engagement. So in the gym that I worked with, we did a study, and 40% of the practice was done without a therapist. So still 60% was being done with a physio or a physio student, but the semi-supervised was about 40% of the practice. So I think really in the gym, it should be that actually most of the practice can be semi-supervised. So that was like increasing the amounts of practice. But when you also think about increasing how hard people work, what we've done with it across the lecture is change the instruction. So we've gone from giving you a very bad instruction to telling you that it was 20 seconds and to count, to making it into a competition. Some people still didn't work very hard, but some people did work harder. So thinking about the instructions, counting and recording the repetitions, having target numbers, all of those things really make people work harder. This is an experimental study that we did looking at different types of instructions. So there was stroke survivors. They would do their practice, and the first instruction was just to do whatever it was. Next was to do 25, so a target number, 25 as fast as you can, 25 as fast as you can, go for your personal best, go, go, go. And this is the results. So we had to measure a new baseline each time. This is repetitions per minute. So under instruction A, which was do 25, people jumped from 16 to 23 per minute, 25 as fast as you can, 16 to 28. 25 as fast as you can. Go, go, go. Go for your personal best. They go from 15 to 30. They double. So really using those kind of goal-oriented instructions makes a big difference to how hard people work in terms of their intensity of practice. This is somebody doing a home exercise program. Okay, so you can see the principle that we're using here is that this man, Brian, he counts and records all his repetitions of practice. And we were doing tele-rehab on Zoom at this time. It was during the COVID lockdowns. So he would count and record, he would send me his sheet, and then we would talk about it at his next Zoom tele-rehab session. And then we'd do things to celebrate. You know, this is in 2 weeks. When he first started the exercise, we're measuring how much is changing. We're quantifying how much is improved. We're counting his repetitions. And he's had this big increase in his walking speed. So quantifying those things. So I think we're up to take-home messages, Mohamed. And then some people might have gone to bed, but if there's people still hanging around, I've got time to answer some questions. But I'll go through the take-home messages, which is that in terms of effective task-specific practice, we need to address the coordination requirements. Think about what muscles work, how do they work, what speed, has to have the appropriate amount of challenge. Improving strength and function, it's about neural plasticity. So we need to set up lots and lots of reps, very specific strategies to increase the amounts of time and the intensity of practice. And that means we need to change our behavior and set people up to practice without us. Change the way we talk about instructions. We give our instructions and use those targets so that people do more practice. Okay.
So our feedback knowledge about the areas of non-performance.
Yes. Thinking about that, that's what was used here this is very much this knowledge of results kind of, but to motivate him. So when we met on Zoom, we would measure certain things, and this one was how long it took to do something. So after 2 weeks, he's doing it much faster, from 16 to 11 seconds. And he was recording his own walking because it was on the driveway. So I couldn't do that on Zoom. So he was going out and doing his daughter, I think, was helping him record his walking speed and number of steps. So that kind of knowledge of results, feedback, some measurement of performance to improve motivation so that people do more practice. Yeah. Okay. So any questions? Well, firstly, if they can possibly just go into too much flexion, that's better, because going into flexion instead of hyperextension is still going to be much better for their walking in the long term. Sometimes if I'm doing walking practice, with somebody who really cannot prevent their knee from hyperextending, then actually getting like a sort of some kind of elastic bandage, and when they're sitting, have them in 90 degrees of flexion and do a very tight figure of 8 bandage around their knee, with their knee in 90 degrees flexion. And then when they stand up with that bandage on, it will make it quite much harder for the knee to go back into hyperextension. So I think that's a kind of a quick, easy technique for improving outcomes. That's not just high reps, is mental practice. That's the only other technique that we really have very clear evidence for. And so we did a systematic review that was published last year in the Journal of Physio, looking at priming techniques in stroke rehabilitation. So where you try and prime the system to increase neuroplasticity. And the only technique that really made a difference to outcomes was people doing mental practice. And what they would do is they would do mental practice before they did their physical practice. And it did change. It did seem to have a beneficial effect on their outcomes. There was some other types of priming that were in the study that didn't make a difference. So action observation, where people watch videos of the task, didn't actually make a difference. Doing things where people were doing some sort of passive movement to the affected limb before their physical practice, that did not make a difference. So the one thing that did make a difference was people doing mental practice. It appears that it probably maybe helps improve their neuroplasticity. Yeah.
I have a question, but it's not about the strength or the coordination or the strength task training that we have spoken about. It was really informative presentation, and there was a lot of new things that I've got to know from this presentation. But I have wanted to know about the spasticity point. Are there other, the spasticity is masking the function of the patient, and it is like not a mild spasticity, it's moderate, and it's doing a huge affection in the patient and masking his function. Are there other certain techniques that we can use to address the spasticity in specific, which will help me deal with it? Like evidence or good techniques?
I think there have been some techniques which sometimes have been shown to have a kind of a short sort of, but I think the problem is that you need to work on the strength and coordination. And even doing those things that have some sort of short-term benefit, probably they're not useful, because the patient needs to be able to practice all the time. So again, I think you just need to come back to your analysis and really doing your analysis and looking at what are the strength and the coordination problems and working on those.
So working with the strength deficits will help me solve the spasticity issues in the stroke patients?
I don't know that it solves the spasticity, but it addresses the main problem, because and people can have spasticity and still be able to move quite well too. And then people can have, when you have a look at, Gavin Williams has these, really interesting videos showing two people with about the same level of spasticity, and one of them cannot walk very well, and the other one is running, and the spasticity is not even interfering with his running. So I think this idea that spasticity is always the problem is really, it's not really sort of born, it's not supported by the evidence. I think we kind of need to change the way we analyze and think and look at the problem and really look at what is weak and what needs strengthening, and what are the problems when they sit to stand, when they're walking, what are their problems, and what are their problems that you can set up practice that they can work on and concentrate on that.
So it's better that we change our perspective from general view to a more...
And just remember too that if we look at the true prevalence of spasticity after stroke, it's probably about 25%. I think the other thing is that often people are looking at somebody and thinking, oh, that is spasticity, but maybe it's not even spasticity. Maybe it's lack of coordination. When people have a very stiff swing phase and they bend their knee and swing phase, and sometimes people think that that is spasticity, that is making them extend their knee and swing phase when it should be flexing. I think probably most often that is actually a coordination problem, and that people are sometimes using their rectus femoris to help. They're using their rectus femoris to help flex their hip instead of just their single joint hip flexors, and so they're ending up extending their knee. So that is a training problem where we need to have a look at the strength and coordination of their hip flexors.
Okay, got it.
I think often, it does come back, I think, often to our analysis and the assumptions. I think sometimes the assumptions are sort of blaming spasticity when it's not the main problem.
Okay, thank you so much.
Dr. Mohamed Hassanin?
Actually, it's not a question. I only want to display that in the last July stroke ED course, there was some evidence has been displayed along the course supporting that spasticity maybe not shaping a primary dysfunction or a primary problem rather than the loss of strength, because when loss of strength is predominant, spasticity come over, and we can't overcome spasticity except if we have much more strength.
Yes.
Do you remember that correctly?
Yeah, I think that's a good point. If you've got spasticity and you've got a lot of weakness, you still just need to increase strength. Yeah.
Thank you. Actually, thank you, Dr. Simon, for your information and your informative presentation. Welcome. You are very welcome here. Thank you.
Thank you.
Another question?
I notice there's a question about mirror therapy for the lower limb from Karim. I'm not that familiar with the evidence. I think there is some evidence for mirror therapy in the lower limb, but I don't think it's as strong as the evidence for mirror therapy in the upper limb. So I haven't looked into it very recently. Certainly we have a recommendation in our guideline that for people with mild impairments in the upper limb, that mirror therapy is recommended. And I know some people have done it to work on dorsiflexion and things too. We did look at it in our priming systematic review as mirror therapy as a type of priming intervention, and it didn't change. It didn't change outcomes. But I haven't looked at it as an isolated intervention. So I think I don't feel confident to say either way about that without looking more. Good night to you.